The effectiveness of the prescribed sedation used for the auditory brainstem response, a retrospective study done by Cassandra Franken. The auditory brainstem response, also known as the ABR, is an objective electrophysiological method of testing the auditory pathway. The ABR is used to measure hearing sensitivity and to study the neuroresponse of the auditory system from the 8th cranial nerve to the midbrain. The ABR is especially useful in detecting hearing loss in infants, young children, and those who have a medical or developmental problem that makes sitting still and responding to the sound of a regular hearing test difficult. The ABR has been used as a valuable screening test to assess infants and young children for hearing loss if they are too young to perform regular hearing testing in a sound booth. Early identification of hearing loss is a necessity as it can lead to significant developmental impairment, speech and language delay, and learning deficits. Infants and young children with hearing impairment benefit from early identification and treatment through the use of hearing aids, cochlear implants, and other assistive methods such as speech and language therapy, sign language, and other forms of educational and social support. In order for the ABR to yield accurate results, testing must be performed with the child completely relaxed and asleep. Accurate recording of the ABR for this population is frequently done during spontaneous sleep, although it might be difficult to time correctly or to induce in a clinical setting for some patients. Partial sleep deprivation and sedation may therefore be required for those who are young and or have cognitive disabilities. The aim of sedation is to reduce movement, physical and mental discomfort and anxiety because they might influence the results of the ABR. Movement is one of the biggest causes of artifact, and excessive artifact is unacceptable. The accuracy of the ABR is sensitive to movement artifact, and an unreliable ABR is likely to result if the patient is not immobile during the ABR. The use of sedation and general anesthesia for the ABR specifically has not yet been extensively studied. The need for sedation and general anesthesia may be increased when children are beyond the age during which deep sleep is easily achieved during the daytime. For the last decade, sedation of children for diagnostic and therapeutic procedures has been a topic of controversy and debate within the medical world. Included in this controversial discussion is the increasing demand for pediatric sedation outside the operating room. Materials and methods. Study population. The group consisted of 38 patients who required sedation with Balagan-Forte and Risperdal to perform objective hearing tests with an ABR procedure at the Neurophysiology Unit of Steve Biko Academic Hospital with the purpose of establishing an audiological assessment. All patients that were used for the study were above the age of 2. For infants less than 2 years of age, an ABR procedure is conducted in natural sleep, and patients younger than 2 were therefore not included. Children older than 2 who could be tested in natural sleep and did not require sedation were excluded from the study. Materials and methods. Study design. This retrospective study was conducted between January 2020 and December 2020. It was approved by the Ethics Committee of the Tshwane University of Technology and by the Ethics Committee of the University of Pretoria in compliance with the Declaration of Helsinki. Protocol and the pre-test requirements for partial sleep deprivation. According to the Neurophysiology Unit protocol, instructions were given to all parents of patients referred for ABR testing to bring their children to the Neurophysiology Unit awake but partially sleep deprived. Partial sleep deprivation was encouraged with late bedtimes, early awakenings, and avoiding naps before the test, especially during transportation to the hospital. Sleep deprivation is believed to help increase the effectiveness of the prescribed sedation. Equipment. A neon-coded neuropack was used to do the procedure. The sound stimulus is delivered via ear insert. 2 sizes of ear inserts are available, pediatric and adult. Headphones may be used in patients that do not have an external auditory opening. The ear inserts need to fit snugly, and care needs to be taken that the delivery tube or the insert is not bent or folded over, as this will degrade or block the stimulus. Electrodes were placed according to the 10-20 International System of Electrode Placement. 5 standard EEG disc electrodes were used and placed on the scalp, namely ground, frontal vertex, central vertex, A1, which is the left ear, and A2, which is the right ear. Sedation. Valium forte and Risperdal were given at a concentration of 3 mg per kilogram and 0.02 to 0.04 mg per kilogram, respectively. According to the Neurophysiology Unit protocol, Risperdal was given first, followed by Valium forte 10 minutes after the administration of the Risperdal. After administration of the prescribed sedation, a pulse oximeter was placed on the patient's first digit to monitor the oxygen saturation. The patient remained in a quiet and dark hospital room in the neurophysiology unit with their parents to allow the patient to fall asleep. Patients with severe pulmonary disease and upper respiratory tract infections had their appointments rescheduled until they were fit for sedation. The patient was weighed and the medical history of the patient was obtained from the parents. For the purpose of the study, recording sheets were compiled to capture specific data. These patient recording sheets were compiled by the neurophysiology technologist who performed the ABR procedure. The recording sheets were completed during the recording process. Table 1 presents categorical data and is described by the number of patients who had successful ABR recordings or not, and the corresponding percentages. Out of the 38 patients that underwent ABR testing, 65.79% of the patients successfully completed the ABR testing. The remaining 34.21% accounted for the patients that had unsuccessful ABR testing. 3 factors that influence the amount of sleep of the patient during the recording were considered. These factors attributed strongly to the number of patients who either had a successful or unsuccessful recording. These factors included partial sleep deprivation, if the patient slept prior to the recording, and if the daytime naps of the patients correlated with the scheduled testing times. This will be seen in Table 2, Table 3, and Table 4. Table 2 presents categorical data and is described by the number of patients that underwent partial sleep deprivation the evening prior to the ABR recording and the corresponding percentages. Out of the 38 patients, 5 patients did not partially sleep deprive, 5 patients partially sleep deprived between 1 and 2 hours, 14 patients sleep deprived for 3 hours, and the outstanding 14 patients had 4 hours of partial sleep deprivation. Table 3 presents categorical data and is described by the number of patients that slept during the hours immediately before the ABR and the corresponding percentages. A total of 35 patients out of the 38 patients did not sleep in the few hours prior to the testing as instructed in the pre-testing briefing. The remaining 3 patients did sleep prior to the scheduled testing time. Table 4 presents categorical data and is described by the number of patients for whom their usual daytime nap period is correlated with the ABR recording time and the corresponding percentages. Nap times did not correlate with scheduled testing time for 37 out of the 38 patients. Only 1 out of the 38 patients' nap time correlated. Sedative dose-related reasons for possible sedation failure were identified, including if the patient spat out the sedation, if vomiting occurred shortly after administering the sedation, if the patient was undersedated, and if the patient had a paradoxical arousal effect in response to the administered sedation. In Table 5, we can see the categorical data, which is described by the number of patients in whom a possible dose-related reason for sedation failure could be identified and the corresponding percentages. Only 12 out of the 38 patients had a possible dose-related reason for sedation failure. In 7 of these 12 patients, an incorrect dose per weight was prescribed. Despite the fact of the underdosing, there was still a very strong linear relationship between the sedation prescribed and the sedation prescribed per weight protocol in the under sedation group. Table 6 presents the amount of time the patient partially sleep deprived the night before testing. Longer hours of sleep deprivation were statistically significantly associated with complete recordings, while no or short periods of sleep deprivation were statistically associated with incomplete recordings. Post-estimation comparisons of the number of hours sleep deprivation and a successful or unsuccessful recording showed a statistical difference. Sleep deprivation for 3 hours and 4 hours was statistically significantly associated with completed recordings with a p-value of 0.0166 and a p-value of 0.000 respectively. There was no significant statistical difference between complete and incomplete recording for the patients that were sleep deprived for 2 hours or less. In this study, we investigated the effectiveness of the prescribed oral sedation for ABR testing and identified reasons for sedation failure. As Table 1 shows, the majority, 25 out of 38 patients, successfully completed ABR testing. All 25 patients that successfully completed the ABR were partially sleep deprived. Longer hours of sleep deprivation were statistically significantly associated with completed recordings, while no or short periods of sleep deprivation were statistically associated with incomplete recordings. Other possible factors contributing to sedation failure, such as vomiting, spitting out of the sedation, under-sedation, and paradoxical arousal effects, were investigated. No statistically significant correlation between these factors and an unsuccessful ABR could be drawn. In conclusion, the current study has demonstrated that 66% of the patients that underwent ABR testing, sedation was effective if a minimum of 3 hours sleep deprivation was adhered to. Longer hours of sleep deprivation were statistically significantly associated with completed recordings, while no or short periods of sleep deprivation were statistically associated with incomplete recordings. This study may provide support for other institutions in developing or enhancing their programs for newborn or child hearing examinations, exploring alternatives to having to resort to general anesthesia for ABR testing.